And welcome everyone to Pediatric Grand Rounds. Our division is excited to host Grand Rounds today, and it's my great pleasure to introduce our speaker, Dr. Ifelayo Ojo. Dr. Ojo is an assistant professor of pediatrics at the University of Minnesota Medical School, and he's a general pediatrician and pediatric hospitalist at Hennepin Healthcare. He received his medical degree at the University of Ilorin in Kwara State, Nigeria, and his MPH at Johns Hopkins School of Public Health. Ife completed his residency in pediatrics, as you heard here at the University of Minnesota, and then he served as chief resident in global pediatrics before joining the Department of Pediatrics at Hennepin and our faculty here at the U. Ife brings to his work wonderful expertise, training, and experience in global health. He serves on the American Academy of Pediatrics section on global health, and he has published and presented on a range of global health topics, including on conducting research in low resource settings and impacts of a global pediatrics curriculum. Ife's other areas of focus include advocacy, health equity, and medical education. In the medical school, he serves as assistant director of the Foundations of Clinical Thinking course and as an assessment and coaching expert. So today, Dr. Ojo will share some of his expertise to help us work most effectively with children and youth in out-of-home care and support families and caregivers. Thank you again so much, Ife, for being here.
Thank you very much, Dr. Boloski, for your very kind introduction. Thank you for having me. I am grateful to the Department of General Pediatrics and Adolescent Health for hosting these grounds today and having me speak. I really feel privileged to be able to be sharing on this topic with you all. I by no means feel like an expert on caring for out-of-home children, but it's a topic and an area that has been of interest to me, and I feel like we can all do more, we can all learn together this morning. So good morning, everyone. Thank you for taking the time this morning to join us. I remember sitting in ground rounds as a resident and giving a few, and then as a chief resident as well. So it's my privilege to be back again this morning to share with you on how we can envision home to support children in out-of-home care. I acknowledge the fact that the land on which the University of Minnesota is located is on traditional, ancestral, and contemporary lands of indigenous people. Specifically, it resides on the Dakota land, which was ceded in the treaties of 1837 and 1851. The more I learn of the history of our country and the complexities thereof, I am humbled and feel like grateful for the work that we all are doing to improve justice, mercy, and be kind and loving to one another, even as we go forward in this space. The main things I hope that we would be able to take away this morning is the, like Dr. Martin Luther King, out of that mountain of despair, so much going on around us, we all can participate in being stones of hope for children and caregivers that are involved in providing care and also receiving the care through the foster care system specifically and in out-of-home care in general. I am hoping that we would be able to pick up concrete tools that we can take away from these grand rounds this morning and formulate a trauma-informed care plan for our encounters with children and adolescents in out-of-home care. I don't have any relevant financial relationships to disclose, neither relevant nor irrelevant. So we'll just start by defining what out-of-home care is. It's any situation in which a child is separated from their primary caregiver, either a parent or guardian, for up to 24 hours. And social services agency has the responsibility for that child during the period that they are out of home. It includes placement in foster homes, which could be relatives or non-relatives, and usually it's about a split within the foster homes. Many forms of care is provided by kins now. We call that kinship care, and I'm sure many of you are familiar with that. It also includes placements in group homes, emergency shelters, unfortunately, residential facilities and juvenile collections as well, and pre-adoptive homes where children are waiting until they are placed in permanent homes because parental rights have been terminated for some reason. The statistics for number of children in foster care in the US is staggering. 1 out of every 100 US children had been through the foster care system in 2020. And in Minnesota, we've had more than 400,000 children remaining in out-of-home care since 2015. This report I quoted here is one that includes children in all the different types of out-of-home care, but more than 90% of them are in the foster care system. So 13,442 children encountered the foster care system in 2020 with 4,812 coming in newly into the system, while there were over 8,000 that remained in the system. And the 167 children in the middle there are both children that exited the system for some time, maybe reunification with their families, and then needed to re-enter for some reason. And I'll speak a little bit more about that later on. So like many other things in this country and in our world in general, there is a disproportionate effect of being placed in out-of-home settings for minority populations. And in the US, the population that is most affected, when we look at this spider charts that I put in here, this compares the population of the group in the country to the population that is placed out of home of those same children. So we see proportionally that the American Indians, Black children with 2 or more races are overrepresented in out-of-home placements. And the stats are very similar for Minnesota as well. When we look at Minnesota, children that are American Indian are 11 times more likely than white children to experience out-of-home care. Bi and multiracial children are 6 times more likely, while African American or Black children are 2 times more likely than white children to experience out-of-home care at for every given year for the years I looked back at. But this was from the report from last year, or report that was released last year for 2020. So now we would have a poll. I want to see, get a sense of how many of us have seen a child with a foster parent in our clinic setting within the last few days, months, or year. I want you to please answer that question, and then we will see. All right, we can share the results of the poll. So this was what I was expecting, really, that majority of us would have seen kids that are in out-of-home placement or with a foster parent within the last 7 days to a month. We see that over 70% of us have seen kids. So 3/4 of those in this meeting at this time have encountered a child from that setting. Let's go to the next question. And this is to get a sense of how much we know or do with the children. You know, when we're giving vaccines, we need consent from a parent. So consent for providing medical care to a child in foster care is obtained from, is it a biological parent, is it a foster parent, CPS, or CPS and biological parents? And CPS I believe we all know stands for Child Protective Services, or protection in some cases. Like, we can share the results of the poll. We got it right. The almost 50% of us got the answer that I was hoping for, which is CPS and biological parents, because they are sharing custody of the kid. The Child Protective Services is taking custody of the child on behalf of the biological parents for a period. So technically, the biological parent is still the one responsible for consents and medical decision-making unless CPS determines that they are incapable of doing so. So it behoves us to find out who the medical decision maker is for the children that we are seeing, so that we can obtain the right consent and do the right thing by these children that come into our clinics. Sometimes we don't think about it for simple things like vaccines, or for things like the fluoride administration that we consider benign or a blood draw. But if we do it the right way, then we get better results, and we're also better able to engage biological parents in the care of their child, which usually the goal is the unification of this child with their primary caregiver or parents. So looking at the report from Minnesota in 2020, or the report of 2020, which was just released in January of this year, the window of opportunity we have is on this slide here. We see that majority of the children, over 40% of them, are in placement for 7 to 24 months. So these children would be in the care of this a foster family for at least 7 months for the most part. The goal on the side of CPS is to pursue the unification for children 6 and under within 6 months of their removal from home. But that usually does not happen due to many reasons. And so most children end up spending at least 7 months in foster care, or majority of children you will see on the latter half of the slide that 1 to 6 or days to months is very few. It's 7 months and above that is more prominent here. So we have a window of opportunity as healthcare professionals that interface with children and families to be able to intervene in a way that would be positive. This also has the racial disparities as well, where American Indians are more likely to spend up to 3 years or more in out-of-home placements. So my hope is that at the end of our interaction with families, or in the course of our interaction with families, the child will be able to point to you and say, that's my doctor. They're excited to come meet with us. They're excited to engage with us. And that would not happen overnight. It would happen in the course of building a relationship. As specialists in this room, we do have a lot of specialists because we're at the university, and we have primary care providers as well. And we have people that work on the inpatient side and people that work in the ICU. This is still something that we all can do at our different levels of interfacing with children and families. However, my slide here is focused on what we do in primary care, or what we're expected to do. From the CPS side and the American Academy of Pediatrics, the recommendation is that the initial medical screen for children that are placed out of home occurs within 24 hours of their placements. And the goal of this is to identify health conditions that the child may be struggling from that require prompt medical attention, or require refills of medications like asthma medications with their rescue inhalers and things like that. You want to make sure that that is available to the child, and things that they are taking chronically for health maintenance reasons are available to them. Also ensuring that we identify any signs of abuse or neglect, infections or communicable diseases, and things that could affect the placement of the child, or determine where this child is placed. And within 30 days of a child being in a new home, they're supposed to have a comprehensive health assessment, which includes review of all their medical records, dental, physical, mental health records. We're supposed to get all of those together and review that ahead of a meeting with them, and then do a follow-up assessment after a month after our comprehensive health assessment. And at that third visit, we're trying to assess the goodness of fit between the child and the family they are placed in, provide more anticipatory guidance. In the process of this, we're building relationships with the child and family that we are caring for. I just wanted to focus a little bit on the individual treatment plan, which is encouraged to be formed by the primary care doctor when we see a child that is in foster care. We prepare that plan after consultation with the family, reviewing all the records that we have, and we share the information with the child or adolescent when appropriate. If it's a baby, we really can share the information with them. But with children that can participate in their own care, we talk to them about what we've formulated for them and let their foster parents know, and as well with their birth parents, their county social worker, their healthcare manager, if there's one separate from their social worker, and we all come to a shared decision about how we would be caring for the child. The plan going forward then is that we would see children, especially babies, monthly up until they are 6 months old. If they are older, we may not see them that frequently because we already have a relationship and a schedule of visits in pediatrics that is planned for every 2 months up to 6 months, but for children in foster care, we do it more frequently every month. If the child is between 6 months and 2 years, we see them every 3 months, at least once a quarter, and at least twice a year between 2 years and adolescence. I would say, though, that this schedule of visits is after we've done the initial 3 visits, which are like a burst of visits and help to build a relationship with our patients and their families. Then one thing I wanted to highlight here is the discharge encounter, where we are to review conditions that were identified during foster care for children when they are going to be placed back in their homes. I have actually never had the privilege of doing this with any of my patients, and I feel it's very important yet neglected, and I think for so many reasons. We know that the CPS system is very busy and has a lot of challenges as well, and so this discharge encounter does not happen, and with the lack of the follow-through on a discharge encounter, some things get missed. And more importantly, the conveying of the summary of health history to the caregivers and whoever the new primary care provider for the child is if we don't get to continue with them. So now I will just pause for a minute and share these 4 questions that I came up with as things that help to get into a level of understanding of what a child that has been placed in foster care is dealing with and what the caregivers might be experiencing as a result of these placements. And I feel like asking the questions to the child works better first before you ask it to the caregivers. The reason for this is the empowerment of the child and recognizing them, giving them a voice, helping them to know they're seen, they're heard, and you care about how they're feeling. In some cases, unfortunately, some of the children we see have not had somebody ask them that question. And in some cases, even their biological parents may not have had the time or the bandwidth to do this. Modeling this kind of behavior in our clinic visits does help the caregiver, whoever they are in the foster care system, a kin of the child, a family member, a close family friend, to see what we expect them to do as well at home. How are you feeling today? Can you share one thing that was a pleasant surprise for you since you started living together? And then asking the child, what has been most challenging for you about your new home? How can I, if you're feeling and you have the space to be able to do that, how can I support you? And if you don't, then offer the support of your clinic. We have a lot of people that come alongside us in the care of our patients in the clinic setting. We have a clinic social worker, we have a community health worker in my clinic. We're so fortunate to have them. And I spoke to our clinic social worker in preparation for this Grand Rounds to ask our opinion of some of these things that we're talking about today. And then we turn to the caregivers and we ask the same questions, but in their own context. What was a pleasant surprise for you, since you said regarding, you named the child, regarding Johnny, since he came into your home? What has been most challenging and how can I best support you? This shows that we care for them as well, because they're doing very important work and in many cases, very challenging work. And we know that it doesn't always go well. It doesn't always go right. And we have an opportunity to stem that tide, to move things in the direction we aim for it to be for the child and the family that is caring for them, or person in some cases. The first time I met a foster parent that was single, I was surprised. I didn't know that was possible. And I was profuse in my thanks for him for taking care of the child that he had brought in for regular asthma monitoring, and how much he cared for this little young man. So some of the things we do in preventive care, I just wanted to raise them also for specialists to think about. Those questions that I mentioned are questions that specialists can ask as well. And I would implore you to think about it and maybe pick one or two that you can comfortably ask in your visit, and things that you can do something about, because you might not have some of the supports that we have in primary care. But on the preventive care side, we talk about just regularly appraising the physical, mental, emotional health and developmental status of the child, regardless of how they are doing on all of those scores that we're looking at. Referring all children under 3 to the birth to 3 early intervention services in Minnesota Help Me Grow, and then advocating for children to be kept in the same school whenever possible, because maintaining routines in the midst of chaos, when one thing at least remains the same, the child feels a little better, and their world doesn't seem as uprooted as it might feel if they had everything change all of a sudden. And then assessing the effects of the child's experiences in out-of-home care on their well-being, and what unique conditions is this child experiencing as a result of their race or ethnicity or their genetic predisposition, and working on and with them to promote their resilience and their ability to cope with these issues that come up. Now we get into the area where I want to talk about how we interface with child protective services. And this is something that I felt like I learned on the fly, not a slight to my residency training or to my preceptors and clinic, but somehow we miss some of these things that we sort of feel, oh, that's what I do, and I expect that you would know it. I also did not go to medical school in the US, and so I was coming from a deficit in that area and not knowing enough about the social system in America, which I think is amazing, yet has its problems. I wish that we had something close to what exists in Minnesota for children in Lagos or in Nigeria as a whole. So though you see the brokenness of the system here, there are some, let's acknowledge the fact that there are some things that are working well, and there are things we all can do to help support the people that are doing the hard work on the CPS side. Not saying that we are not doing very hard work too, but to be able to collaborate with them so that we can better improve the care we provide to children. So first order of business now for me is finding out the name and telephone number of their CPS caseworker. And then I flag the chat. There's an ICD code for it, actually. It's child in foster care. Just type it in and you put it on the problem list so everybody knows that the child is in foster care. And when the child goes back home, you can always resolve the problem. You should resolve the problem. It's a pet peeve of mine for people to throw things on the problem list and then not take it away when it's resolved. So you list the foster parent's name, phone number, their address, you list who the medical decision maker is, finding out from the person in front of you if the parent is there by themselves, and I mean the foster parent, and there's no county social worker. I've actually never had a county social worker come to any of my visits. I've had interactions with them on phone, but never in person. And then you offer multiple copies of your AVS to the person who brought the child so that they can share with the county as well as the biological parents when appropriate. I also put in here because I know that we are not superhumans as the doctors, nurse practitioners, or providers seeing the child to do everything. We can enlist the help of our clinical care coordinator or social worker. We should actually enlist their support in reaching out to CPS caseworkers to find out more about our patients' past medical history, their social history, the reason for the placement, what they are anticipating in terms of expected duration, how they are working with the families to get the child reunited back with their birth family when that is possible. And then because we have a sense of the duration, we can reach back out to them after the reunification has happened to find out what kind of supports and supervision is available for the birth family. And in this area, I feel like it's hard. It's you can't keep everybody on your mind and on your reminder list. And so it requires a little bit of extra work to make it happen. And I'll be open to hearing ideas that people have for doing this. And this information on this slide I got from our new mental health worker who has worked with CPS for a period before she came to Hennepin County Medical Center, Miss Annie Jesset. And she was really kind to spend time with me to share a lot of this information regarding the CPS side of things. So this leads me to a sad story, and it's of one of my primary patients. It's my only primary patient that has died. He was an infant, died at 9 months, and he had a presentation at one of our affiliate hospitals with non-accidental trauma. They placed him out of home for a few weeks. I don't know how long. It may have been a few months. And then he was reunited with his birth family. I saw him once in clinic, not with the mom who had been the person that had been bringing him to the visits, but now with the dad. And I did my usual thing of asking after mom and about her well-being and all of that. And dad assured me that she was okay. And subsequently, I didn't see them again for about 5 months. And the next thing I get was a fax that said the patient arrived dead by EMS. And the cause of death was thought to be due to non-accidental trauma. And that just shook me and got me thinking about how this could have been different. I didn't know in my wildest imaginations that anything like that could happen. And there's still a lot of investigation going on as to the cause of the infant's death. But this report that was published it's an article that was published in Pediatrics in September of last year, talks about infant deaths from medical causes after a maltreatment report. And that's not even infants that are screened in for an investigation or infants that are placed out of home, just reported for some reason to CPS. They are at a higher risk of death from medical causes. We know that they are at a higher risk of death from non-accidental trauma. We know that they are at a higher risk of death from neglect and other factors surrounding their social networks that are broken down. But seeing this, that they could die from medical causes as well, is sobering to me and just tells me, gives more work to each one of us, specialist, primary caregiver, knowing that improved communication between us and CPS may prevent death. We may be able to stem the tide of some of these deaths, because in conversation, what are we really hoping to find out? How is this child being taken care of now that they're back in the home? Or in the case of when there's a report that has been made, I hope that someday there would be a system where we know when a report has been made and we can talk to families about that, or at least approach them with that lens, not out of a bias, but knowing how we can treat them with more tender, loving, trauma-informed care, such that we can get better outcomes for our patients and their families as well. Now, I want you all to just reflect for a minute, for 2 minutes, just think about how you approach your encounters with children that are in foster care and what you're going to be doing differently. Would you be reviewing the chat differently? Would you be assessing for the adverse childhood experiences? Would you have a conversation before examining the child, or examine the child more thoroughly? What's your plan? What do you intend to do differently? And then the other question I have is ways that we have shown support already to caregivers of children in foster care. And I'm hoping that we can put some of those things in the chat. If there were any tools you utilized, did you use a checklist from the AAP or from Foster in America or from your clinic? Do you have a unique tool that you use? I mean, just sharing how you show your support and how it was received. I would love to see a little bit of that. And we can also stand up, take a little bit of a stretch break, get some water to drink if you need to do that. And then I would look back at this in 2 minutes. Thank you, Dr. Bowman-Shop and Dr. Scal for sharing those. And the interesting thing is, if we were in person, I was hoping to have 2 brave souls come share, and then it was 2 people that shared. So I'm like, oh, it kind of read my mind. Dr. George, thank you as well. Yes, the idea of just slowing down, looping in social workers, bringing in our care coordinators, and letting the child and family know that they are seen, they are heard. You give them a gift, a reach out and read book. I feel like one of the greatest gifts we can give to a child is the gift of being able to read. And it offers an escape too for this child from their world. Sometimes from all the things they are dealing with, they just can go into the book and just leave out their imaginations in there. And Dr. Borowski talked about listening, empathy, gratefulness to them, thanking them for coming to us, and thanking the families for bringing them to us as well. Thank you all so much for sharing this. I believe that the rest of us that didn't share also did something important during this digitally divided world where it's hard to sometimes get the energy up to do some of these things. I hope you were able to stretch and get a drink of water and things like that to continue to fuel your body and mind during this stretch that we're in. Right. So I wanted to switch gears a little bit and talk about a little bit of our advocacy work as pediatricians. I got a chance to do some work on this when I did an elective as a resident, actually, at the American Academy of Pediatrics. Dr. Bowman Chopra and our residency leadership were kind enough to let me go back to DC when during my first year to do this elective. And I got to work with the AAP staff to advocate for kinship care and the increase in support that the families need. We know that they are less likely to receive benefits and other support services than other foster care providers. And many times they are the ones that need it the most. Some of the kin providers are grandparents that were not expecting to have a baby in their home going forward, or an adolescent come live with them. And in some cases, they are siblings, older siblings of the little child we're seeing. So these stats are really troubling that only 17% of them receive childcare assistance, 15% of them are seeking housing cost support. So as pediatricians, we can advocate for them to get better support, and we can also direct them to some of the places where they can get support, especially if they are trying to adopt the child, which many times the kinship caregivers are more open to doing, and they're eager to get it done early as well. One of the things that we have in the state of Minnesota is the Department of Human Services, and they have on their website financial support for foster parents who want to adopt the children that are in them. And I looked at this list and it's quite comprehensive. I've not attempted it myself, but when we look at this kind of resources, we can click on some of those links and see where it takes us, so that we're not sending people to blank spaces where they'll just get caught in bureaucratic paperwork and more burden to them than they already have. So the other thing I wanted to talk about now is in terms of the child themselves, the children themselves that come to us from the foster care system. And that's something that Teresa Fong also just highlighted, the fact that the child is more than a patient. They are children, and because they are children, they have the needs that all children have, and they want a loving caregiver. And I would get into the attachment theories a little bit at the end. But it was interesting to me when I walked into a hospital room for a child that was admitted just overnight and was trying to get the mom to open up a toy that was given to her by Child Life. And mom was on the phone, but when we walked in, she promptly stopped the call. But this child was still there trying to get mom, open this thing for me. It was a 2-year-old who was not yet verbal. And mom was still not paying attention to her because now the doctors were in the room. And I stooped down to the level of the child and talked to her, helped her to open up the toy. We played with it a little bit, and we talked for maybe about 15 minutes. When it was time for me to leave, she was crying. And that just broke my heart, that this child in 15 minutes seemed to have formed an attachment with me that was not being given to her by her mom for all the many reasons that mom is going through. Mom had another infant at home who was in the NICU when they were born and had spent many months in the hospital. So it was clear how this child may not have had a good relationship with the mom prior to coming to the hospital, but modeling that for the mom, I hoped that there would be some improvement. And then I referred them to our mother-baby help program, and hope that that connection happens sometime, because the last time I checked, it had not happened yet. But when we are approaching our children that come into our clinic, assessing for the impacts of the trauma they've experienced on their mental and physical well-being, and doing a safety check. Miss Jordan Gustafson, who works in my clinic as our social worker, shared this with me. She wanted us to know to check for suicidal ideation, making sure that they are safe, especially for adolescents, checking for signs of abuse, and then building a trusting relationship with the children that we see, and using a tone of voice that is calm and pleasant with them. They talk about parent ease, where we all go high pitch, how are you doing today? And stuff like that, or you go low pitch and use a voice that the child recognizes that this person is safe. I can talk to them even when I am so upset and crying. We can walk through this together because the doctor is calm. They're not just throwing their stethoscope at me as they're walking into the room. They are not just talking about vaccines as soon as they walk into the room. I've made that mistake too many times, maybe about 3 times, but those 3 times were traumatic enough that I've decided I'm never going to do it again. Don't talk about vaccines until the end of the visit, please, because many children are so scared of the vaccines that you just lose the rest of the visit if you do that. There's a reason that the vaccines are at the end. And so getting excited about the fact that we have the COVID vaccine and we're offering it to kids now is something that I got too far away into. And I got some tears and had to take a walk around the clinic with my patients to calm them down to then be able to continue the encounter. So please ask for consent prior to physically touching a patient. Even if it's a baby, it's okay to say, hey, I'm going to be listening to your heart. You're talking to the baby about what you're doing. It helps them develop language as well. And the idea of offering a choice to the patient whenever possible. Let's give them some control in a situation where they have very little control, offering them choice, and partnering and collaborating with the children and their caregivers as well. Because we know that trauma could reduce their ability or their desire to share what they're going through or whatever health concerns they have. So it's in a partnership and collaboration that we get to make that happen. So these are just some basic things in attachment that I thought would be good for us all to remember, because I liked the acronyms that were shared by Dr. Heather Fockey when I attended the child abuse summit that was put together by our University of Minnesota group. She talked about same, that children need the same thing from all adults. They need safety and security. And this is both physical and psychological. They need us to be available to them. They need us to think with their mind in mind. What is going on in this child's mind that could be causing this behavior? Not what is wrong with you, but what happened to you and what can I do to improve that experience going forward? And being an emotional container for the kid, not letting our own emotions get ahead of us or our anger at whatever happened to the child, but being able to set that aside and provide the care that the child in front of us needs, being available to them, attuned to them, responsive in an appropriate way to them, and being consistent in our approach to them, not doing things that would be seen from the child's perspective as bailing out on them or doing things that they might consider unhelpful or scary. We know we do need to give the vaccines, but talking to them in a way that they would understand it and letting them know there are options for helping them feel less pain. We have a lot of things in our clinics. We have the Buzzy Bees, we have EMLA, we have options. So I finished with this thought, and it was interesting that Dr. Bowman Shop mentioned reach out and read, because I was like, that's something most of our Minnesota clinics have. Bringing a gift for the child, I think, is really nice when you can. And I know that reach out and read is for kids up to age 5. Sometimes I cheat and give it up to age 8 or so, because the whole objective is to encourage reading. Early reading, much better, but some of our children that we're seeing are not reading yet at age 7. I read a few pages with them, encourage them to point out words on the page. If it's looking embarrassing, I take it on myself and just continue the reading and point out things to them. So think about things that you do differently. What are you going to bring with you to your next encounter? And I leave you with that. I would be open to questions. I would be open to people just sharing their thoughts and letting us all learn from the things that you are doing, because I'm sure you're doing a lot of wonderful things already. And I would love for us all to be able to learn from that. Thank you.
Thank you very much. We have a few comments on that question from guest Teresa Fong, who loved your suggestion for having those 4 kind of standard questions to use at the beginning of the appointment to set the tone for establishing that relationship between the patient and provider and the caregiver. Thank you for the positive presentation. And then just hoping to kind of revisit what you brought up about who can give consent for treatment. So you kind of alluded to finding out who their CPS worker is, but I wonder if you have any practical experiences of asking the foster provider and they perhaps didn't know, or do you feel like that's pretty, like every time you've asked, they did know?
Yeah, thank you, Dr. Bowman-Shope. So, and thank you, Teresa, for your comments. I appreciate it. The consent, I have had it go both ways. I have had asked the foster parents and they're like, I don't think you can give vaccines because they're just with me for a few days and we don't know how long this is going to be. And then I say, would you mind giving me the number and the name of the CPS social worker if we had not done that already? And so they give that to me. And sometimes I try to reach them right away in the clinic just to talk to them about that. But if they are not reachable or the timing does not allow that, then I take the information, put it in my little notepad and my problem list where I list that. It's in the overview, the name and number of their social worker, and then we connect with them afterwards to find out who the medical decision maker is for the child. Usually the foster parents would know, but sometimes they don't know and it's ambiguous to them as well.
Yeah, I think kids who are experiencing out of home placement are certainly at significant risk for getting behind on their preventive care, including vaccines, but also you can't spend an hour and a half tracking people down during your regular visits. So I think that's where that frequent follow-up that you talked about is so important. Kamara Gustafson asked, could you share suggestions for concrete tools being used in specialized clinical settings, such as specialty clinics, inpatients, or emergency department, to provide support to caregivers of children in foster care?
Thank you, Dr. Gustafson. The last time I did a presentation like this at Hennepin, Dr. Gustafson was actually co-presenting with me, and she works in the emergency room, as some of you may know, and she also does care for children in our adoption clinic. And some of the things that we envision can be utilized in the emergency room setting is the idea of assessing the safety of the child. When children come to us, the emergency room is a place where many times that's the entry point for children to be seen for the first time in a long time, because sometimes their caregivers are evading the system because they know that some things have happened that they don't want other people to know. And in the emergency room, if it's a foster parent that brings the child in, usually that step has been crossed already. Somebody has become aware that something not right is going on in this child's home. And so for them to be in an emergency room or a specialty clinic, then there's something acute going on or there's a chronic health problem. I feel like the same questions that we ask to all other families: how are you feeling? And what can I do to support you? What is challenging right now? Sometimes it's a simple response from the pulmonologist. Oh, you don't have to use the NEB machine. It's actually preferred and quicker for you to use an inhaler with a spacer device. This is how you use it. We demonstrate that to them, and it feels like, oh, that's so easy. I can do that. And so there are practical tools we can use. And in some cases, the emergency room also becomes like the continuity of care for some families, because that's all they know. And that's the place that is easy for them to access based on their own schedules as well. And so when we're seeing families over and over again, making a plan to care for them and looking out for the interest of the child, I am open to hearing more suggestions from Dr. Bowman Shope, who has been doing primary care much longer than I have too.
Well, I mean, I've already been learning and thinking a lot about the all the things you've been saying. And, you know, one of the things that I always try to think about is how can we try to make the like best version of care available for all of our patients and not make assumptions about what they would be able to use. Like, you know, my chart access of don't make assumptions about a family's language proficiency and whether they'd be able to use it or not. Offer it to every patient because they may still be able to use it. And that particularly the digital access to the health record, I don't actually know the rules about that, but it just, these kids I think are at such risk for fragmented care, and the online portals are becoming increasingly where you can know, oh, they have this appointment coming up. Oh, that appointment actually got changed to 10 o'clock instead of 8:30. Oh, you know, here's this questionnaire we're supposed to fill out. And as the rest of the system is really moving towards digital access and digital reminders and text message reminders, if we can't find a way to bring kids and out of home placement into being a part of that system, they'll get care that's potentially less good. Yes, I wondered about that, Dr. Gustafson. So I don't know, maybe we should think about some way for them to have it, or a limited version, or like if they can't have it, you know, one of the things I've been doing a lot, because our clinic has had quite long phone waits lately, is giving people the like secret backdoor number to the clinic, like call this number and it will get you, you know, right to the nurse line, because we want to just remove any barriers. So those are the things I try to think about, is like making care really easy. And I tell people to put this number in your phone right now. This is the one you need for this clinic. If you can't get what, that's where medical home comes in, right? Like, this is your place. We will help you get what you need.
I think Dr. Boloski was going to share something as well. I love the idea of telling adolescents to sign up on my chat, because I do that as well. I get their cell phone number, throw it in the chat, and encourage them to sign up for my chat. I send them a text right away so that they can do it. And sometimes I'm like, do you want to sign up right now, while I'm doing something in my notes? So I am doing my notes. They are signing up for my chat. Dr. Boloski, what are you going to have?
Yeah, thank you so much for a wonderful talk and making us sort of slow down and think about what we can do to just make care wonderful for these families. And I wondered if there are just one or two things at sort of the systems level, the advocacy level, that you would recommend we can make an impact on as pediatricians.
Thank you. I think the biggest one in my mind and on my plate has still been the getting more support for kinship care providers. And that's why I highlighted that bit, because I feel like I know a family right now that they are paying for all of the medical care for this child. They can afford it because they are well off. But if they were not able to afford that, I cannot imagine what it would look like. The baby has been with them since he was born. Now he's 14, 15 months old, and they've not gotten any support from the county. They say because it was not an arrangement through the county, they don't have a right to do that. And yet there are some things that were a barrier for them. Fortunately, now they have the My Chat access. I don't know how they were able to make it happen. I'm not asking questions. They have it, and I'm like, good, so we can communicate that way. But I think having the government recognize them and support kinship caregivers more, and because they also tend to be under more stress, unfortunately, things can go more south for children that are in those settings. And so recognizing that and knowing that we can do things to improve their care. I'm thinking that if somebody is signing up for kinship care, if we can arrange for them to also have a mental health worker, somebody that checks in with them on their own mental health, how they're doing, and supports them practically to be able to transition to having a new person in their home that they were not expecting. And then the other thing I was thinking about from the advocacy level is just the idea of us pediatricians advocating for better connection with CPS and the coordination that could be happening at that level. When I read that article, they used CPS reports in California and death records and vital statistics. Like, I don't want to find out at the end what could have been. I would rather have the information at my fingertips prior to the things going badly. So when reports are made, yes, it seems like we're overstepping to find out that, oh, somebody reported this family, but it's helpful for us to know, because then we know that, oh, there's a risk in this situation. And unfortunately, it's the risk of death. It's not neglect. I mean, it's bad for a child not to be developing well, but for them to suffer the loss of their lives because of the lack of support in many cases, and just all of the things that their caregivers are dealing with, I think is very unfortunate. So if we can better coordinate with them, I know many of our clinics, and maybe all of our clinics, are trying to put support systems in place for families to identify postpartum depression, to work with families that we consider high-risk social situation. We have an EPIC code for that as well. But apart from those preventive things, when there are glimpses that things are not going the right way, it will be helpful for us to know. So I feel like coordination with CPS would help with that.
Thank you.
Well, I think we are about at time, but thank you so much for such a wonderful talk and just a chance for us to pause and think about how we can best support some of our kids and families who are going through a really challenging time. And I think it gave us all things we're going to go out and try to do better in the next week or month when we encounter someone who's in out of home placement. So thank you so much for a great talk, and everybody have a great Wednesday.
You're welcome. Thank you for having me.
Bye.